Today we are going to discuss nephrotic syndrome, and in the previous lecture we had discussed what is nephrotic syndrome and what is nephritic syndrome, what are the primary causes of nephrotic syndrome, what are the secondary causes of nephrotic syndrome, and same like what are the primary causes for nephritic syndrome and what are the secondary causes for nephritic syndrome. So of course, like secondary, it is when it is secondary to certain conditions, like if it is secondary to SLE or secondary to diabetes or secondary to any XYZ amyloidosis. So of course, like uh, you must know when you will study that condition, so you must know this association, like they can result into nephrotic syndrome. So in this lecture, I would like to start my story with this thing that whenever there is nephrotic syndrome or nephritic syndrome or uh, any condition related to kidney. So in one of the lecture we discuss about what are the investigations we can do. So one of the investigations which we can do in kidneys is called as biopsy, right? So I will start my story with renal biopsy because renal biopsy is such an important procedure. Uh, Without that, we cannot make we cannot reach the final diagnosis, like either it's uh, like nephrotic or nephritic, but what kind of nephrotic or nephritic syndrome, right? So we cannot reach the diagnosis. So I would start my story with renal biopsy. And what is renal biopsy? Nowadays, they do like FNAB or FNAC, fine needle aspiration biopsy or cytology. So basically, what happened is uh, there is some requirements. For example, the blood pressure should be less than 160 by 95 millimeter of mercury, and or there are different protocols related to different countries or different hospitals. You have to follow them. The HB should be greater than 9, and one very important thing, the platelet count should be greater than 100 in order to proceed for renal biopsy, and the clotting profile should be done. Okay, because of course, like after after renal biopsy, if like any of these things are abnormal, maybe the patients will start bleeding, and that can prove fatal for the patient. And of course, like we explain the procedure to the patient, we get a consent before doing any examination. We always tell the complications to the patients, like we tell the what we are going to do, why we are going to do, what are the alternatives, and if we will not do this thing, so what can happen, and if we will do this, then what can happen. So of course, like we tell them the complications, we tell them that um, what kind of procedure it is. They will be having some back pain, maybe they will be having hematuria, okay, for a few days. Maybe they have bleeding, maybe they need a blood transfusion or things like this. So we always tell them the complications, okay. And after procedure, there should be bed rest for 4 hours at least, okay. And of course, in this 4 hours, uh, what should be done is like the monitoring. We should monitor their blood pressure, pulse, urine color, and things like this. So of course, like when the hematuria will be settled, then you are going to discharge them back home. And if the patient is taking any drugs like aspirin or warfarin, so they can start taking it. They should stop taking it before the procedure, and they should start taking it after the procedure. Like anyone who is on aspirin, they should stop taking aspirin at least 1 week before the procedure. If you know like what is the function of aspirin, you like the things will become easy for you. If the patient is on low molecular weight heparin, so they must stop taking that before 24 hours. Because of course, like we don't want bleeding or we don't want excessive bleeding. So then they put a needle and they can take a small piece of the kidney tissue, and then of course they see it under the microscope, and they tell like either it's a focal or segmental type of condition. Sorry, focal or diffuse. Sorry, or either it's segmental or global kidney involvement, right? They tell like either there is any hypercellularity, or you can say which will tell either it's a proliferative type or non-proliferative type. Either there is any scarring or sclerosis is there, right? So like this thing. Um, Other things which will which they can uh, give you is like either they what they see, either they see IGs or they see light chains, okay, or they see complements, okay. So in the kidney, of course. So how the podocytes look like, either there's any inflammatory signs, all these things, of course. And based on this thing, of course, we may make the diagnosis, okay. What kind of glomerulonephritis is there, okay, and depending on that, like we decide the rest of the things. So now if we know like what about these things, then of course like we would understand, okay, this patient have nephrotic syndrome, and either it's a minimal change disease, either it's focal segmental glomerulosclerosis, either it's membranous nephropathy, either it's membranoproliferative glomerulonephritis. So like this way, right? Consult the previous lecture if you won't understand what I'm telling you. So in this lecture, we are going to discuss what is nephrotic syndrome, how many pathological types are related to nephrotic syndromes, what are they, what is the most common complications of in nephrotic syndrome, what is the main treatment of nephrotic syndrome, how to use steroids, and the side effects. The side effect of steroid, of course, I'm not going to discuss them. So nephrotic syndrome we had discussed yesterday, guys. What is that? What is going to happen? I'm just scrolling it down. Okay, I already explained this thing. Like if you open this lecture, so uh, go and see the lecture which I uploaded before this one, which is basically a lecture says parenchymal kidney diseases, nephrotic and nephrotic syndrome, right? So like all this explanation we had done yesterday, right? So this thing I told you, like this is the normal kidney and this is like in nephrotic syndrome. Glomerular basement membrane, see this one here. These are the major processes. These are the food processes. These are the filtration slits. So what's happening over here? Food processes are fused like this, right? Okay, and see like it becoming leaky. So all the proteins they leak out simply. So this thing, okay. So like this is like showing what is proteinuria. Anyhow, I already explained to you yesterday that whenever there is proteinuria, the patients they present with edema. And see, this is pitting edema. Non-pitting edema occurs in conditions when there is lymphedema. Okay, lymphatic systems is blocked. But of course, in this one there will be no lymphedema. Rather, there is pitting edema. Okay, so see this one ascites, right? So now uh, these all pathophysiologies I already explained yesterday. Just scrolling it down. Actually, I explain the things better, when I write it in my own way. So that's why, like, because that lecture was more about, you can say, making concepts. So I use that one. But this lecture is more about, you can say, showing you the things or remembering the things. Okay, these are the pathological types, right? Like this, basically, this thing we will come to know after we will have the results of renal biopsy. Then we would know, okay, either it's what kind of condition it is. So the first one here is minimal change disease, right? It often happens in children and teenagers, they present with edema, pleural effusion ascites, renal function is usually normal, blood pressure is usually normal, hematuria, always present as nil or just microscopic range, where gross hematuria is very rare. If you remember that nephrotic concept which I showed you yesterday. So this one, because MCD comes completely towards nephrotic side, so hematuria is rare. Basically, it causes like around 25% of the adult syndromes, nephrotic syndromes, 25% of the time it is the cause. And most of the time, this one is idiopathic. Most of the time. It could be due to, I'll see if it is written over here, wait. Okay. So, most of the time, it is idiopathic. Mostly idiopathic. But it can be due to drugs, okay? Like NSAIDs, okay? Like lithium. Or it could be due to some malignancies like Hodgkin lymphoma, they may have the same thing. One thing, guys, this minimal change disease, it rarely or does not cause, you can say, renal failure. Okay, so it rarely cause um, renal failure. Rather, clinically they say, like, if, very important point, by the way. I think it's such an important point that I can write it over here. If there is renal failure, then consider a missed focal segmental glomerulosclerosis. Okay, if there is renal failure in the patients who have minimal change disease, think about a missed focal segmental glomerulosclerosis. As I told you that, how they name it as minimal change disease, because when we see it by under the normal microscope, we don't see any changes. But when they see it under the electron microscope, they found that the podocytes, they are fused together. Okay, like the podocytes, there is effacement in that one, like they are separated from each other. So what happens due to that, it become leaky, and the proteins, they started leaking out. So this is what is the presentation of this thing on electron microscope. Okay, and that's why it is called as minimal change disease, because previously they keep on finding why the patient have this condition, but when they fail to found at that time, they don't have the best microscopes. But when there is invention of new microscopes, they found that the patient have minor changes, so they name it as minimal change disease, right? So okay, make this concept, I don't know like how many of you understand until now, we know the clinical features of nephrotic syndrome. So whatever we are discussing minimal change disease, FSGS, or whatever, the clinical features will remain same, right? Now, how we treat these patients is basically we give them prednisolone, okay? We give them steroids simply. So the good thing that 75% of the adults, they respond to steroid therapy, okay? Basically, you can say like up to 75, up to 90%, right? But it mostly like 75% around. But many of them, they have a recurrence, like relapse. Half of them, they relapse. They again had minimal change disease, right? So what is done, like what we do, what we give them, we can give them prednisolone, okay, for 4 to 16 weeks. This is how they treat them. And what is the dose? Like, you don't have to remember the doses, but it is very easy to remember, 1 milligram per kilogram. Okay. So see, we are giving for 4 to 16 weeks, and when we stop the steroids, we taper the dose off. We make the dose low, 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 and then we stop it. Okay. So if someone have, relapse, again, they have minimal change disease, then of course you will give steroids. But if they have again one more relapse or recurrence, so we cannot continue, you can say, steroids for so long, then we can give them what you can say steroid sparing therapy, in which we don't give them steroids, rather we give them some other drugs. Which are steroid sparing drugs? These are immunosuppressants, right? So we give them immunosuppressants. Okay. Just remember, few simple names: cyclophosphamide, okay, or many others. So many other drugs can be given. So cyclophosphamide we can give. This is about minimal change disease. Okay, one of the condition which I want to show you is focal segmental glomerulosclerosis. Now, focal segmental glomerulosclerosis is the most commonest glomerulonephritis, you can say, seen on renal biopsy. So, like whenever they send the, you can say, whenever we do renal biopsy in the patients, this is one of the most common like abnormality which can be seen on the renal biopsy, right? So commonest glomerulonephritis seen on renal biopsy. It could be primary, or you can say idiopathic, or it could be secondary. Whenever it is secondary, it is present, or it is in association, or it is secondary to patients who have HIV, who abuse heroin, who use lithium. So lithium is a very important drug, see. Or again, minimal change disease can occur in Hodgkin lymphoma. This one can also occur in lymphoma. Okay. And what happens, like, because there is sclerosis, so the kidney size are basically smaller. So when we do ultrasound, we found like the kidneys are smaller in these patients. So now, there will be features of nephrotic syndrome as well as renal function will be damaged progressively. So ultimately they will lead to what? Renal failure, okay? Ultimately they will lead to. So, by the way, one very important point, guys, I want to mention over here is what? Around up to 50% of the renal transplants are basically done because of focal segmental glomerulosclerosis, because many of these people they end up in renal failure, so we go for renal transplant. So again, the pathology, the name show focal segmental sclerosis is there. Okay, so you can see over here, this is the classic focal segmental glomerulosclerosis. See, focal and just few of the segments that are involved. So they have like different variants. A collapsing glomerulopathy or tip lesion is there. So this is the light microscopy of focal segmental glomerulosclerosis. You can see this all tissue, right? So of course diagnosis will be by, of course, on histology, okay, and then of course we go for the treatment. So this one is not that much steroid sensitive like MCD or minimal change disease. So one of the point which is not written over here is simply, sorry, what we do in these patients is, we give them ACE inhibitors, okay, to control the blood pressure. ACE inhibitors or angiotensin receptor blockers, ARBs, for hypertension, we give them, right? And they are not sensitive to steroids, but they can be given. Or you can say steroid therapy only when it's idiopathic, okay? We give them steroids. So the treatment, by the way, which is usually used for these patients are calcineurin inhibitors, right? So we can give them calcineurin inhibitors, okay? So, but like most of them that, they end up in kidney transplant, okay? Remember guys, the last thing for whatever you will study in nephrology, sorry, what you will found, like the last or the ultimate thing which happens to the patients is renal replacement therapy. And that's why I'm going to teach that thing in the last, okay? So this is the main point, that we are going to study that thing in the last, because like that is the final treatment, okay? Okay, then there is membranous nephropathy. 25% of the time on renal biopsy, we found like the patients had, they come back as membranous nephropathy, okay? Adults, I'm talking about adults. Again, it could be primary, it could be secondary, same thing, okay? This one could be primary, it could be secondary. Whenever it is secondary due to malignancies, infections, and immunological conditions like SLE, rheumatoid arthritis, sarcoidosis, and things like this. Again, it could be due to some drugs. Okay, so you can say causes of this thing: idiopathic, and it could be secondary to it is secondary to malignancies, lung carcinoma, breast carcinoma, infections, streptococcus infection, malaria, hepatitis B, hepatitis C, immunological, SLE, rheumatoid arthritis, sarcoidosis. It could be due to drugs, gold and penicillinamines. Okay. So what happens in these patients? The features again. Remember the features of nephrotic syndrome. No need to go and read the features again and again. What we found in these patients is antiphospholipase receptor antibodies. What we found is antiphospholipase antibodies. So this is the best thing, best diagram I can show you. What is this? Like they're doing fluorescence microscopy. So see the things, they appear colorful. What are these? Is basically there is IgG, okay, IgG's deposit, okay, which we can see over all these things, okay, and see there is thickening of the glomerular basement membrane, GBM. So these two things, one IgG's, second thickening of glomerular basement membrane. You can see over here, thickening, okay. So this is the thing, which appear, like how they appear on the microscopy. So what happens in these patients is, once the diagnosis is done, again, we give them for blood pressure. To control their blood pressure, we can give them ACE inhibitors or receptor blockers, angiotensin receptor blockers for hypertension to control their blood pressure. And how to treat them? Now see, what's the thing we found? IgG deposits, antibody deposits. So how the condition can be solved? By immunosuppression, right? So how we can suppress their immunity? By steroids and cytotoxic drugs. So what we give them corticosteroids plus cyclophosphamide. Okay, by the way, guys, you can give other immunosuppressive drugs as well. I am just talking about cyclophosphamide again and again. There are many. There is azathioprine, there is cyclophosphamide, there is tacrolimus, there is many more, right? So this is how we treat them. So we can give them this thing. Basically, this regime is called as Ponticelli regime. This regime is called as what? Ponticelli regime. Ponticelli, Ponticelli regime. So what immunosuppression do? Like, by the way, the immunosuppression is more useful in the patients who are positive for antiphospholipase A2 receptor antibodies. Okay. So this is the treatment for this one. Okay, so there is Mesangiocapillary glomerulonephritis as well, MPGN. Okay, and what's going on in this one is there is C3 deposit and IgG deposit, right? You can see over here. See, immunofluorescence, right? So there are, I told you, many others, of course, like which are not so important, right? Not so common. So proliferative. Wait, where it is? Okay, here. Okay, glomerulonephritis. Of course, like it is. It have two types, IgA and non-IgA. Okay, and what is happening in these patients is simply this is a pathology. When we do immunofluorescence, we can see IgAs, depositions like this way. Okay, so simply these immune complexes can be seen. So one is like membrano-proliferative glomerulonephritis. It causes like 10% of the nephrotic syndrome. So not so important. MCD and FSGS are the most important, right? So simply there can be C3 glomerulopathy or immune complexes associated. And the treatment remains same. We give ACE inhibitors and ARBs for blood pressure control. Okay. And we can give them immunosuppressive drugs. Okay. Whenever, of course, like there is this IgGs and IgAs and complement systems are involved. So, of course, like the main point is to uh, what you can say treat by immunosuppression, of course, right? So anyhow, guys, like what we are studying now is basically nephrotic syndrome, and we had a discussion yesterday for nephrotic syndrome, right? What is the final thing? What is the complications of nephrotic syndrome? Now, see, the complications can be infections, which could be anything. The complications can be, I told you, they become hypercoagulable. They can be thromboembolic complications like hypercoagulability is there. A complication can be acute renal failure, which is, I told you, chronic renal failure is the last thing for many renal conditions. Or there could be proteinemia, hypoproteinemia, or hyperlipidemia. Okay, so these are all the complications. Okay, so like this is what you can say they are associating. Decreased albumin is there, so there will be edema. Decreased transferrin is there, so that's why these patients are microcytosis, anemia. Decreased hormone binding proteins will be there, so the patients will be having hypothyroidism. Decreased vitamin D binding protein, so they may have osteomalacia, and decreased endothromboin 3, they lead to thrombosis. So now I think like what is the diagnosis there. We don't have to talk about that thing again and again, right? So simply, we found the patients, they have pitting edema. They, especially we check their sacral region, their ankle region, around the elbows in bedbound patients. Okay. So we ask in the history about the systemic symptoms, joint, skin, malignancy, chronic infection. We investigate what the cause, hepatitis B, C, what drugs the patient is taking. You can ask for the investigation. Then the most important investigation you will ask for is which one? Of course, you will ask for renal biopsy, right? So how it is treated? Okay, differential diagnosis, like again, I don't go through differential diagnosis because still like you guys are left with a lot of conditions, okay? Though like you know this thing, we had done this thing, Henoch-Schonlein purpura. So I don't talk about differential diagnosis because that's a different game. So how we treat is what is our aim? The first aim is to reduce edema. Second thing is to treat the underlying cause. One aim is to reduce proteinemia, and one aim is to reduce complications, right? Of course, we ask the patient for bed rest. We put them on salt restriction. We also put them on fluid restriction, okay? This is also very important for edema control. Fluid restriction. Around 1 liter per day they can take, right? Because we don't want them to develop more and more edema. So once that is done, you have to reduce edema. We can give them diuretics. We can give them loop diuretics like furosemide, thiazide, potassium retaining, osmotic diuretics, okay? Anything can be given. So what they do in the hospitals, they do their body weight every day. They just see like either they are decreasing weight or gaining weight. Okay, so the aim is to reduce, you can say, around half kg to 1 kg weight every day. This is the aim. Okay, to reduce half kg to 1 kg of weight every day, because to reduce edema. So first of all, the best diuretic is to start with furosemide, and if needed, we can add a thiazide diuretic. Okay, so loop diuretics, they work good. So if needed, they can be added with thiazides. If there is too much less, you can say, proteins, then we can give them albumin injections. Expensive, but a very good treatment. Okay, so for blood pressure control, we give them this thing. Okay, and then the specific treatment, of course, either you will start steroids or you are going to give them, we see like either they are responding to steroids or they are like resistance to steroids. So trial can be given. These are the side effects of steroids. We have discussed them many times. And if anyone has side effects of steroids or they cannot take steroids, we give them immunosuppressive drugs. Okay, makes sense. So this is like all the names of drugs. So now, how to treat the underlying cause? Of course, like when we know, for example, if it is due to some condition, a rheumatological condition, a cancer, a drugs, of course we can treat that. ACE inhibitors and ARB inhibitors, they are very good for blood pressure because they also reduce proteinuria. And now, how to treat or prevent the complications? Of course, we can give them antibiotics, which we can give to renal failure patients, okay, to prevent infections. For thromboembolic events, because they are in hypercoagulable state, and they have low antithrombin, okay, they have platelet abnormalities, so there is risk of this thromboembolic events. So what can be done is we can start them on heparin, or we can put them on warfarin. Okay, go basic, or other therapy can be given to these patients, right? And one of the thing is hyperlipidemia. So of course you will give them the cholesterol lowering drugs like simvastatin or atorvastatin, statin groups, HMG CoA reductase inhibitors. These are basically the statin groups which we can give to these patients, of course, because we have to reduce their lipid levels. Okay, so these drugs can be given. The prognosis, MCD have the best prognosis. Rest of them, many of them, they end up in acute renal failure. This is a case analysis you can read, guys, and you can solve it. Male 12 years old student had nephrotic syndrome 3 times since 7 years of age. 6 years ago had upper respiratory tract infection, presented with edema, small amount of urine output, blood pressure is this much, ankle edema is there, RBCs are not there, proteins are positive. So serum albumin levels and blood urea nitrogen creatinine levels are given. What is the diagnosis? Okay. What should renal biopsy be carried out? What can be the most common cause, pathological type of glomerulonephritis is there, and how to treat, right? So you can solve this thing, a very good practice. Okay, so that's all for now for nephrotic syndrome. Thank you so much for listening.